Hi, I'm Jeff Mandel, and I want to describe my poster, A Pharmacoepidemiologic Method for Assessing Clinician Performance During EGD Procedures Sedated with Propofol. I have no conflicts of interest. Endoscopic sedation with propofol is one of the most common tasks of anesthesia providers. No objective measure of anesthetist performance has been described. A data-driven metric would be useful for assessing performance of both humans and algorithms. IRB approval was obtained to review all upper endoscopies performed at the University of Pennsylvania over a 2-year period from a de-identified data store. 13,503 cases were analyzed. This was comprised of almost 28,000 boluses and almost 33,000 infusion rates. There were some patterns of delivery that were apparent, looking at initial bolus versus age and weight, and initial infusion rate versus age and weight. And we can conclude that weight plays a limited role in choice of initial bolus. Age above 60 reduces the initial bolus. The initial infusion rate is based on weight and is reduced by increasing age. But there was an adjustment from the initial dosing in the majority of cases. 2 derived measures are proposed. An adjustment dose, which is how much the control changes from the initial settings, and the trajectory error, how much the ranking of cumulative propofol within the cohort changes over time. Starting with raw data for infusion rate and bolus, we develop a sample data stream for infusion rate and project the initial infusion rate out to the end of the cohort of 20 minutes. We then calculate the difference between the intended rate and the actual rate, the shaded blue area, to determine the adjustment dose. Trajectory error is determined by looking at the actual cumulative propofol dose over time for the entire period. We then look at the ranking within the isodeciles for cumulative propofol administration across the whole cohort, and to develop the score, which is the ranking from 0 to 1, the standard deviation of which is the trajectory error. We can see the distribution for adjustment dose, and that there was no correlation between adjustment dose and age or weight. We can see the distribution for trajectory error, and again, no correlation between that and age or weight. We can also see that there was no correlation between trajectory error and adjustment dose. So we can conclude that trajectory error and adjustment dose are independent of age and weight and independent of each other. This suggests these are measures of the controller, not of the controlled. These measures may be useful in assessing the performance of anesthesia providers delivering propofol for endoscopic sedation, but the ability to demonstrate improvements in performance over time will require further study. And I thank you.